Kia ora everyone, my name's Diane Kenwright. I'm a pathologist from Wellington. One of my interests is eye pathology, and I've invited Andrew Sangster here today so that we together can talk about the pathology of common causes of blindness in New Zealand. So Andrew here works for Sangster and Matthews Optometrists in Wellington. And I'm very pleased that he's going to be able to give us some clinical insights. So what are the leading causes of low vision in New Zealand? So the first is macular degeneration. Would that be the most common, Andrew?
Yeah, that's pretty much the right order for them there. Macular degeneration would be by far the most common. Glaucoma, while not so common, is definitely age-related. So we see a lot more of it in older people.
Yeah, and then diabetic retinopathy and cataracts would round off the four top causes of low vision in New Zealand. So, you know, 180,000 Kiwis have low vision, and you can see that on this chart here that it's a disease of older people, with half of the people being over 80, but also a considerable number of, you know, that middle group, 22 to 64, has low vision as well.
Yeah, I'm guessing that that would be most likely because of the diabetic retinopathy. That's going to affect that age group more commonly than any of the other conditions.
Okay, so let's think about some of these conditions. So people often think about pathology is about looking down microscopes, but really pathology is about the whole disease. So we're going to talk a bit about what causes the disease and what causes it to progress. And of course, with eye pathology, we can look down the ophthalmoscope or the slit lamp or other technology to actually see the pathology in the eye. So I'm going to concentrate a lot on the clinical pathology in this talk. Let's start with age-related macular degeneration, which is the leading cause of blindness and low vision in New Zealand. And 200,000 of us will have ARMD. That's a really high rate. 1 in 7 people will get it.
It is quite high, yeah. And there are two types, although they're sort of variations. The most common is what's called dry macular degeneration, and that's kind of an atrophic aging degenerative condition of the macula. And the wet is a neovascular variant of that. And although it makes up only 15% of the number of people with macular degeneration, it makes up a significantly larger proportion of people with vision loss.
And it looks like it's increasing as well.
Yeah, we're all just getting older.
Yeah, we are. Okay, so the next cause that we'll talk in detail about in a moment is diabetic retinopathy. So 330,000 Kiwis have diabetes, and like up to a quarter of those will have diabetic retinopathy. That's more than I thought.
It's a lot of people, and it tends to affect the younger demographic, as showed up in the pie graph earlier, and it tends to be people with type 1 because they have it for longer. They often get it as children or adolescents, and so they have a lifetime with the disease. So even with the best management, they will probably acquire some diabetic retinopathy over time. And with type 2, they tend to get diabetic retinopathy primarily due to poor control and also late detection.
Right. Okay, so and then the glaucoma, so less common, 90,000 Kiwis, but seems to cause a lot of low vision, that being the second most common cause of low vision.
Yes, and part of that, I think, is because a significant proportion, half of people who have glaucoma don't know they've got it because it's painless and it's a very, very gradual progressive disease. And so people neuroadapt.
Yeah, so does that mean they present late?
A lot of people do. We try and screen people, anybody over 40, we will screen them as part of a routine visual examination. But of course, not everybody comes to see an optometrist.
And then cataract. So, cataracts is really, really common. We all know people with cataracts. The thing that surprised me with this is that we've got like over 300,000 Kiwis with cataracts, but only 30,000 operations are performed every year.
Yeah, I think that that's a pretty good reflection. A lot of people will have cataract where it's not actually impacting significantly on their quality of life at this stage. So of the 370,000 Kiwis with cataracts, I think a significant number of those will be people who don't need to have any intervention at this stage. That said, there is a huge waiting list for cataracts to be done, and that shows up in the prioritization score in the various DHBs, or whatever they're called these days, around the country. And for Capital Coast DHB, as an example, pre-COVID, the CPAC score was 45. Now, the CPAC takes into consideration quality of life factors, which are used to sort of weight the score over the clinical presentation and the potential outcome. And but 45 was sort of just on the cusp of driving standard. So it was a very timely intervention, I felt. But post-COVID, with all the deferral of the less life-threatening procedures, that score has pushed out to over 60. Now, if you've got a CPAC score of 60, you are being significantly impacted on in terms of quality of life with regards to how poor your vision is.
So let's have a look at some of these in more detail. So, excuse me, with age-related macular degeneration, surprisingly a 50% chance of inheriting the risk.
Yeah,
so
it's quite common genetically. Yeah, it's certainly something that we routinely ask in our history when we take is there a family history of macular degeneration there, because it does increase our suspicion index as people age.
And smoking.
Yeah, smoking. It's the first of the big. It's the biggest of all the modifiable variables. And people who are relatively heavy smokers, like 20, 25 cigarettes a day, it increased their incidence of macular degeneration risk by about 30%. So that's quite significant. And they tend to get it younger too, about 10 years younger.
So with ARMD, we think of things that increase the risk of getting it. But once someone has started down that path, there are also things that like exacerbate it. They can make it move faster.
Yeah.
Yeah, and diet's one of those, isn't it?
It is indeed, yes. And
also obesity. We'll come and we'll talk about diet.
We'll talk about those in a bit.
Yeah. Okay, so diet. Here we go.
Yeah, so diet. I mean, there was two big studies done in the States in the 1990s called the AREDS and the AREDS 2, the age-related eye disease study. It was a big multi-center study where they followed a few thousand people over the age of 55 for many, many years, and sort of pulled the data out. And this slide here is a pretty good indication of some of the risk factors they saw. And probably the one that I tell people when I'm talking to them about trying to modify their risk is the dark green leafy vegetables. They contain flavonoids, lutein and zeaxanthin, which are both have anti-inflammatory properties. And lutein in particular is found in quite high concentrations in the macular area of the eye. And they found that if you had a decent diet of these dark green leafies, there's a silver beet, spinach, broccoli, dare I say it, kale, then it can significantly increase, decrease your risk
of progression.
Yeah.
Yeah.
And also with regards to the fats, I mean, in New Zealand, probably a bit like Argentina, we probably eat a little bit too much of that red meat, and omega-6 has a pro-inflammatory effect. And so really we need to reduce our red meat intake, but also increase our omega-3s. So you reduce omega-6, increase omega-3s. Now that's obviously fish, and nice sort of oily fish, so your salmons are particularly good. But if people are intolerant of eating fish, then it's the grains and the seeds which are important.
So I've seen dietary supplements promoting eye health.
Yep.
And they've got these things in them.
Yes, and the things they've got in them have these were the things that came out of the AREDS 2 study, which were shown to actually be beneficial with slowing the rate of change. And you've got your antioxidants, your vitamin C and E, you've got your lutein and zeaxanthin, your anti-inflammatories there. Also, there's a couple of support minerals in there too. Zinc and copper is also good. In the AREDS 1, they actually had beta carotene, a precursor to vitamin A, in the mix. But when they did the AREDS 2 and actually looked at it in a lot more detail, they found that the beta carotene made no difference whether it was in there or not. And so in the modified supplement, they actually took it out.
So I chose the supplement that I've illustrated because it was the cheapest available in New Zealand at $33 a month, but that's still quite a lot. And I'm not sure whether it can be prescribed. So
yeah, I'm not sure about whether it could be prescribed, but $33 a month, that's 33 times 12, we're talking about $400, aren't we? So it's quite a lot of money. Now, obviously, if you can afford it, it's well worth it if it's going to prevent how much vision loss you have over your life, but it is still a cost.
Okay, so age-related macular degeneration, we've been talking about it as driven by inflammation. And of course, cardiovascular disease is also driven by inflammation. So if you have patients that have indicators of risk of cardiovascular disease, like a high CRP or high homocysteine or high BMI, they're also likely to get ARMD. So anything you can do really for cardiovascular disease is going to reduce their risk of incidence of ARMD as well. So wet ARMD, so it's a progression from dry ARMD, and is much more like it progresses faster, more visually devastating. But what surprised me is that any stage of ARMD, any stage of dry, so it could be quite early ARMD, can suddenly become wet.
And nobody really knows what the trigger is. That's the other thing. So it just seems to be an unfortunate circumstance with people developing wet ARMD.
So let's have a think about what's actually happening pathology-wise with ARMD. This is the normal retina. It's got 3 layers of neurons here. It's got the photoreceptors, and then it's got all the neural connections between them. But ARMD happens right here at the bottom of the retina, where we've got the retinal pigment epithelium and this barrier called Bruch's membrane. It's a bit like a blood-brain barrier.
It's a lot like a blood-brain
barrier.
It's a lot.
It is like it is. All right. But these days, Andrew has this marvelous instrument called an OCT. So
it's pretty standard through optometry now.
And it lets him see all the layers of the retina. So do you want to explain what's happening here? What's this OCT picture?
You can see here that we can see the structures. In some ways, it's almost like a histology slide. You can't see the individual cells, but you can certainly see where the cell bodies are, where the neuronal connections are. This pale layer at the top here, this is the retinal ganglion cells, and they get thicker as they aggregate together as they head into where the optic nerve is here. You have the little dip here, which is the foveal pit. Of course, there's no retinal vessels over the fovea, and so it drops down to get better diffusion from the choroid underneath the retina. And you can see all the layers here. This layer just in here, the darker layer, that's your photoreceptors. Then you have your retinal pigment epithelium, and then you get the outer limiting, or the inner limiting membrane. I always get these outers and inner confused because of the way the eye is structured, but we get there.
So let's have a think about what's happening from a pathophysiologic point of view. So here we've got a normal retina, and normally here down in the choroid, the nutrients and oxygen move up here through the retinal pigment epithelium to help the photoreceptors do their metabolism, and any material that is generated, that's waste material, goes into the choroid. But as people age, what happens is this transport through is impaired, and so these photoreceptors become a bit stressed, and the waste material is also not able to be moved away as well, and so it starts collecting here in this basement membrane. And then in early ARMD, what happens is the waste material starts forming these little humps called drusen. And drusen have a pro-inflammatory effect. They activate complement. And we start getting inflammation in the retina. Plus this energetic crisis happens because there's less transport through. And then finally moving into the later stages of dry ARMD and wet ARMD. So here we start getting lots and lots of retinal pigment epithelium loss, and we get the glial cells forming kind of scar tissue in the retina.
And you get photoreceptor dropout.
Yeah, these photoreceptors are looking pretty sick now. But in wet ARMD, the key thing that happens is you get breaks in this Brooks membrane, the blood-brain barrier, and you get lots of little vessels growing through. And that's the key thing that makes it really bad. So I'm going to ask Andrew to explain this lovely picture of the fundus here.
Okay, this is this is a moderate dry macular degeneration, and you can see in the macular area here there's these sort of large, pale, slightly fluffy yellow accretions, and these are the drusen. So you can see how they sort of just cause distortions. Because they're rough, they cause distortions in the photoreceptor layer above, and that shows up where straight lines and things aren't quite so straight. So with the Amsler grid sort of maps over the macula here, and so any distortions in the grid will be reflective of distortions that are happening due to the drusen.
So looking here at the
yeah, here's a good one here. Yeah. You can see this in the OCT. You can see how these drusen do look a bit like a bunched up rug, and you can see what it does to the photoreceptor layer above that. And yeah, I'll let Diane talk about the histology.
Yeah, so here we've got the drusen that's accumulated all this waste material. It's between Brooks membrane here and the retinal pigment epithelium, and you can see the photoreceptors actually being distorted. It really is like a shag pile rug that's being like pushed out of the way.
And in here, what's happened, this is a wet form, and there's been a break in Brooks membrane. And what happens is then you get a hormone called vascular endothelial growth factor, or we call it VEGF, which is then transported out of the retina. And what that does is it stimulates new vessel growth, and you get neovascularization coming in under the retina between Brooks membrane and it causes distortion. You can see the RPE becomes quite damaged. And as well as the neovascularization causing distortions, you get leakage of fluid, and you get this like this dark lacuna. This is actually fluid under the retina as well. And you can see how the retina is bulged forward, which is going to cause considerable distortion. But also the rods and cones in this area here will not be functioning very well at all, because they are away from their normal ability to get nutrients through the RPE and back out again. And we call this CNV, which stands for central neovascularization.
Yeah, and the histology shows a similar picture where this is Bruch's membrane, normally intact, now with a hole in it, and you can see a wee vessel coming through and starting to proliferate here. And
yeah, and this is an advanced CNV. So what's happened here is we've had a neovascular outcropping in these areas here, the little one here too, and it looks suspiciously like the new little neovascular vessels, which have much weaker walls. They've leaked, and so we've got a little bit of a hemorrhage going on here. There'll no doubt be there'll be a lot of edema here, and so we'll be starting to lose visual function. It will be very, very distorted at that point there, and probably has lost some central vision.
And this looks even worse.
Yep, this is getting right out towards late stage neovascular. So again, you can see the break in Bruch's just here. You can see fluid here. You can see the neovascular membrane here. And also what's happening now is the fluid is leaching forward. And so we're getting these sort of bullous kind of intraretinal fluid. And this is causing a lot of damage to the photoreceptors and the neuronal connections between the photoreceptors and the retinal ganglion. And that macula, you can see, is horrendously distorted now. So really, macular function is not really there.
And histologically, we can see this is the layers of the retina here. We can see the photoreceptors now are pretty much completely destroyed. This is the fluid in the retina. This is Bruch's membrane, and these are the little vessels growing through it. So almost as good as the black and white picture.
Almost as good as the black and white picture.
Okay, so finally, the final stage of macular degeneration.
What happens is then you get fibrosis, and so you get scarring, and this isn't good. So you get scarring and atrophy. So these very pale areas here, these are views of the sclera, because there is now no retinal structures to sit between that and the sclera underneath. And you can see significant damage in this here area here, and we call this because it's kind of got a round shape to it, generally we call it a disciform scar.
Yeah, and then here's the OCT of a disciform scar. You can see the big amount of fibrous tissue now under the retina, and here's the histology. This is the layer of neurons, but the photoreceptors have completely gone now. And this is all scar tissue, completely irreversible. And down here is that Bruch's membrane. So it just ends up in a big scarred mess, really.
Yeah.
Okay, let's move on to the glaucomas. So the glaucomas are a collection of diseases that have the pathology. The pathology that causes them is at the front of the eye, but the damage that they do is at the back of the eye. And so mostly we think of glaucoma as being associated with raised intraocular pressure, but about 30% to 40% of people with glaucoma don't seem to have raised intraocular pressure, but still lose vision. Can you explain that?
Yeah, we call that normal tension glaucoma. And I suppose that's a bit of a misnomer in its own right, because what is a normal pressure? We have a normal distribution curve for pressures where the median's 15 and one standard deviation is 3 either side of that in millimeters of mercury. But we'll get people with pressures of 17, 18 who have glaucoma. Now, this comes down primarily to the way that we actually measure pressure. And the way we measure pressure unless you are in a glaucoma specialty clinic where they have some pretty cool toys now, we usually do it by indentation. So it's either a puff from a non-contact tonometer causing a dent in the cornea, or else it's applanation tonometry where we're actually touching and pushing onto there and then taking a read of the pressure. Now you can imagine that these are standardized to a normal thickness of the cornea and assuming a certain standard of hysteresis, of flexibility of the cornea. And if the cornea is thicker than average, then it's going to be more resistant to indentation. And so you're going to end up with an artificially high pressure. Conversely, if you have thin corneas, and the extreme of that would be something like keratoconus, because it's so thin, it's going to be far more malleable to indentation, and so you'll get a lower pressure. Now, those pressures then aren't really an accurate reflection of what the pressure is really doing to the structures at the back of the eye.
So a relatively insensitive test, so pretty good, but
it's used well. It's an indication, but it's not a diagnosis. And certainly, if someone's got I'll back that up. We're looking at other things other than pressure. We're looking at structural change and also psychophysical change.
Oh, psychophysics.
Yeah, good word. Yeah. And so we're looking at how things change in terms of structure at the back of the eye and how that may affect the visual field.
So glaucoma is a bit like an optic neuropathy, isn't it?
That would be a good way of defining it. It's an optic neuropathy, and it's an optic neuropathy that is related to poor perfusion of blood in the microcapillaries in the optic nerve head, in the optic disc, which is sort of the last port of call for nutrients and oxygenation for the rather long axons which go from the retina all the way through to the lateral geniculate body.
All right, let's think about the types of glaucoma for that, and what's happening in the front of the eye. So we often think about glaucoma as being primary or secondary to something else. And we often think of it as having like an open angle or a closed angle. And the most common kind of glaucoma is the primary open angle glaucoma. So
it's by far the most common.
I'm going to briefly revise the way that fluid's produced in the anterior eye. It's produced by the ciliary body here. It then travels round the end of the iris and is absorbed in the trabecular meshwork. And the primary problem in primary open angle glaucoma is here. It's not absorbed properly. This meshwork becomes all plugged up. And so the pressure inside the anterior part of the eye increases.
Well, the volume increases, which then pushes the vitreous back against the back of the eye.
Yeah. Well done. And sorry about that. But while it's the very, very most common cause, and the changes in the trabecular meshwork are age related, it thickens up, it accumulates debris just because of age. Sometimes other things can happen in the eye which also plug up that meshwork. One of them is this pseudoexfoliation syndrome, which is an abnormality in the breakdown of elastin fibers, and it kind of creates dandruff in the front part of the eye, and all these little flakes come round and plug up the meshwork there.
It's more common in Scandinavian people.
Right.
There you go.
Yeah. I was just thinking of Danneberg.
Yeah. Well, I don't know, maybe. And another cause is what's called pigment dispersion syndrome or pigmentary glaucoma, where what happens is you get pigment loss off the posterior surface of the iris, either due to it rubbing against the lens as the pupil constricts and dilates, or just general loss. And again, you get pigment which then floats around in the currents and also is deposited in the angle there in the trabecular meshwork, causing a secondary blockage. Another one too would be perhaps somebody who's had a trauma to the eye and has had perhaps a bleed or a hyphema. That can also cause a raised intraocular pressure as well.
So it looks like we've got another OCT here, but the front part of the eye.
This is an anterior OCT.
Yeah, and these angles, they look pretty narrow.
Yep. Now that can be structural, so it can be a genetic factor, but sometimes these narrow angles aren't this narrow when people are younger. What happens in people who have a propensity to narrow angles is, as we all age, the lens, as it hardens, it also thickens. And as it thickens, it pushes forward on the iris and causes the iris to bow forward. And this can narrow the angle even further and can lead to closure. Now, once it reaches a certain level of closure, then you get the acute angle closure glaucoma, which is a much more easily diagnosed kettle of fish. But the chronic angle closure can be intermittent, so it can happen overnight sometimes when the pupil dilates. And as the pupil dilates, of course, the iris folds end up going into the angle and cause another potential cause for blockage. Right.
And the one I see the most is where new vessels form in the angle here and tack this iris down to the back of the cornea. And the new vessels often form in diabetes because the eye is a bit ischemic and a VEGF is released, but also after occlusion of the vessels at the back of the eye.
You get a similar effect, yeah.
Yeah. So who's at risk? Well, African peoples are at highest risk. Where Pacific people actually have a lower risk, but the biggest risk is in people over the age of 60 and people who have a family history. I didn't realize it was such a big risk.
Yep. Again, it's one of those questions we always ask, do you have a family history of glaucoma? Because again, we just then put those people on a higher risk index in our minds, and it's always written in big letters on their file because you don't want to forget.
And people with steroid eye drops as well.
Yeah, prednisone in particular is probably the one there. Also oral prednisone, if they're on it for long periods of time or high doses for a period of time, that can increase the risk of increasing intraocular pressure and causing glaucoma. But certainly people who are on prednisone eye drops, we have to be wary if they're on them for any great length of time. Some steroids, because of their formulation, aren't absorbed so well. So those are the sort of the anti-allergy type steroids that we might use. But ones like prednisone and Maxidex, dexamethasone, they tend to absorb quite readily and therefore have a higher risk of triggering glaucoma and cataract too.
So this next slide shows the field changes that we see in glaucoma, and people often describe a classic arcuate scotoma. Would you like to explain that in terms of pathology?
Yeah, well, again, if we go back to where the optic nerve was, if you get a localized area of ischemia at the optic nerve, you're just going to get a small region of nerve fibers that are going to shut down. But those nerve fibers radiate out onto the retina. And so what you end up getting is you get this classic sort of fan, this arcuate shape, which always respects the midline because that's how the nerve fibers go. They go out and around inferiorly and superiorly. So they always respect that horizontal midline.
Okay, so this is the classic diagram that we're always shown med school,
If you think of the retinal nerve fibers, the ganglion cells coming in, they kind of create, as they come in, they kind of create a donut of nerve tissue that drops into the optic nerve. And although we talk about the size of the cupping, what we're really looking at is actually how much donut there is. And you can see that compared to this one has hardly any donut left at all. So we would be anticipating that this person would have significant visual effects from from their glaucoma. This one here potentially is a normal looking disc to me with a normal looking cup. And we look at that, we look at the thickness of the nerve fiber layer in each quadrant. And it generally follows in terms of thickness. It's thickest inferior, superior, nasal, then temporal, which spells isn't. And if it isn't, it isn't good, was a little mnemonic we used to have.
Okay. So if we think about the histology of the optic nerve, where all the action is happening in glaucoma, this is the back of the eye, this is the cup here, and this is the nerve fiber layer here that we were seeing.
That's the donut.
Yeah, that's the donut there. And all the nerve fibers come back and they pass through the lamina cribrosa here, which is like a bit of connective tissue. It's like a sieve. And so it's this bit of the optic nerve that's actually getting infarcted when these microvessels are affected by the pressure, but also the lamina cribrosa is affected by the pressure, and it thickens up, meaning the axonal transport back to the brain and this part of the nerve fiber is impeded. And so this is another reason why they die. The third reason, and this is relatively new, is that it's not just intraocular pressure, the pressure effects, but as the nerve fibers react to the pressure, low-grade inflammation occurs. And inflammation in the retina is really bad. So we get cytokines released, and then T cells are attracted, and then the T cells cause apoptosis of the neurons in the retina. So direct damage by a different mechanism. Okay. All right. So this is complicated.
This is pretty. Okay, this is an OCT printout where what we're looking at here is, if this is the optic nerve in the top left-hand corner here, and you'll see there's a green circle. What the OCT has done here, it's taken hundreds of scans all the way around, sort of radial scans around here, and it's measured the thickness of the retinal nerve fiber layer at those points. And from that, you can plot it out in many ways. So for this one, for example, it's taken, I won't say quadrants, I'll say octants, no, hextants. And it's given you an average thickness in these regions. And you can see that the ones inferiorly are significantly thinner than the ones superiorly. So you go, oh, hello, there's probably a little infarct or something happening down here. And when you look at this color map, which looks at overall thickness of the nerve fiber, where blue is thin and yellow is thick, you can actually see the infarct here, and you can actually see that radiating accurate effect coming out like this. It's always going to be a bit thinner in the macula because it drops down, that foveal pit we talked about before. And if you sort of do it like a little heat map, you can go, bam, there it is. There's that area of nerve fiber loss. You can also look at it a different way, where if you take that green circle and snip it at the nasal side and then lay it out like a bit of string, it becomes the x-axis. And then you've got the thickness on the y-axis, so you can actually rock around the clock. You can see nasally, superiorly, it's looking pretty good. Then we drop into the inferior temporal region, and there's obviously significant loss there, like so. And that shows up in the scan graph here as well. So it's many different ways of looking at the data. It's very sensitive, so we can see subtle changes. This is quite a dramatic one. But if we have a series over time for somebody, we can actually see subtle changes in the nerve fiber layer, which is detected before there's any visual field loss. And we call that pre-perimetric glaucoma. Now, unfortunately, we can't get those into the public system because there's people with far more advanced glaucoma filling up the waiting lists there. But certainly, if we can, we get them in privately and get some treatment before this, because obviously the sooner the better.
Okay, let's move right along and think about diabetic retinopathy. So again, this is the diagram that we recognize from medical school, showing proliferative diabetic retinopathy. So diabetic retinopathy goes through several stages. There's the pre-proliferative and then the proliferative, and then we come out with all this pathology. So I'm going to ask Andrew to explain it on this eye, which is a real photograph.
Yeah, this has got the whole dog and pony show. So we have little dot hemorrhages scattered around. We've got little teeny tiny microaneurysms as well, which are the formation of the earliest formations of neovascular change. The little bleeds, we get the dot hemorrhages, of course, we get the blot hemorrhages, larger blot hemorrhages here and here. They are actually sort of lower down in the retinal layers. And then you get these little flame hemorrhages, which happen in the retinal nerve fiber layer. As well as this, because of the poorer circulation, you get areas of infarcted nerve, and these cause sort of these soft, fluffy, pale spots we call cotton wool spots. But also we get leakage from the vessels, which leaves you with these placoid, these sort of proteinaceous, cholesterol-y, plasmary, highly reflective, hard deposits. And as well as that, down here, you can see these little fine fanned vessels like this. This is neovascular change. There's a whole lot up here too. And these are little tiny shunt vessels that have been created to get around areas of poor circulation. And we refer to these as IRMA, I-R-M-A, which stands for intraretinal microvascular abnormalities. Also what can happen, and you can see it in here, we get beading in the vessels. The veins become quite irregular in their shape. And also you can get occlusion. So down here we've got a little ghost vessel where we've had an occlusion happen.
So it doesn't start like that,
no.
Fortunately. Fortunately, it starts pretty mild with just a couple of changes.
Yeah, we've got a couple of little dot hemorrhages and a couple of little microaneurysms here. And if we were seeing this, we would refer this person with this degree of change probably annually.
And then we go through moderate changes.
Yeah, now we're starting to see some more changes. Again, we've got the dot and blot hemorrhages a little bit more present, and sort of in that paramacular area. We've also got some hard exudates happening. And so with someone like this, we might review them 6 monthly or 3 monthly.
And then severe this is still
pre-proliferative. Pre-proliferative. So
yeah,
there's some debate. Some of the more experienced optometrists who are working in the retinal screening programs may well still keep these ones and keep a watch, but I would be referring these to see a specialist, just because those little hemorrhages are so close to the macula. If we get a decent bleed happening, it's going to impact on the vision.
Okay, so let's think about the pathophysiology of what's going on. Diabetes is quite a complicated disease in its pathophysiology, but there are 3 things that we need to really think about. We need to think about, all the oxidative stress and inflammation that's happening. That's the first thing. So remember, we were talking about inflammation before with the other retinal diseases, and how if we get cytokine release, we get white cells going in there and causing apoptosis. So some of that's happening as well. The second thing that's happening is actually in the little vessels. So the hyperglycemia can cause these complexes to form in the walls, which makes them very weak and can kill off these wee parasites here. And so what you get is you get the little aneurysms and you get proteins leaking out. The other thing that can happen with the vessels is they can become occluded, as Andrew pointed out before. And all this means that there's very poor perfusion to the retina, which causes release of VEGF, and then new vessels grow out through the walls here, and you get some astrocyte degeneration as well.
And the walls of those vessels are very weak, so they tend to leak, which causes the deposits we see and also the hemorrhages. Another interesting thing to sort of bear in mind here is when we, looking into the eye, it is the only place where you can actually look at and see vasculature just sitting there looking at you. And we must remember that these changes are actually happening elsewhere in the body too, in similar vessels.
It's true. So I do some renal pathology as well. And if the person's got bad diabetic eye disease, then I know that similar things are going to be found in the kidneys when I get a biopsy. Okay, we better move on to cataracts and finish off. Yeah. Okay, so people often think about cataracts in the lens as, this as if the lens was kind of this uniform thing, this uniform cake, but it's not. It's got different parts, and the different parts can have different cataracts in it. So if we move to this diagram here, the lens has got a nucleus, a central, very cohesive, firm part, and it can get a nuclear cataract in it. And then around the outside, it's got the cortex, which is much more fibrous. And the cortex can have a cataract in it, a cortical cataract. And then there's a special kind of cataract that happens right at the back of the lens called the posterior subcapsular cataract. So let's think about each of those in turn. So nuclear cataracts, probably the most common cataract?
Yeah, probably, but only just. I think there probably are more nuclear cataracts, but cortical cataracts are certainly up there as well in terms of commonality. And the way I describe a cataract to people is I say, imagine that the lens is like a translucent gel inside a cellophane bag. And what happens throughout our life is the gel hardens and sets. And which is fine. It's why we end up having presbyopia and needing reading glasses. So when you get to about the age of 60, the lens has got about as hard and as dense as it's going to get in terms of flexibility. But what happens then is it still continues to harden. And as it does so, it loses its organization. So it becomes less translucent.
Goes brown.
Yeah, discolors. So you get that yellowing, and you also lose transparency. So with the yellowing, of course, that means that you get a lot more light scatter at the blue end of the spectrum. So they tend to lose that color, not that they're aware of it. But yeah, I mean, Monet is a classic one that's brought up in this situation. So you lose the blues, they're getting lost in the lens through absorption and scatter. And one of the comments is when people have their intraocular lenses put in, is they are just blown away with color. Everything's bright, obviously, and they've got better contrast, but it's the color, it's the blues, the reds, the purples. It just sort of blows them away for a while until they get used to it again.
Excuse me. So the cortical cataract, so you've got the nucleus, and then it's surrounded by these like fibers which also undergo degeneration. Yeah, and it's also really common, but often glare can be a predominating symptom.
And when you look at these with retroillumination, where you bounce the light off the retina, or if you actually look at them with your ophthalmoscope, you'll actually see these cataracts look like spokes. And of course, the light catches in the spokes and it causes this glaring, this flaring effect. So car headlights are very dazzly. Street lights will have halos and flare off them. And it can be quite disabling, especially on bright days. So in a social setting, if someone's facing a picture window, they may not be able to see the person with their back to the window. They'll lose the facial because of all this, the facial recognition, because of all the scatter of the light coming around.
And the posterior subcortical cataract is like a brown area at the back of the lens, and people often complain of not being able to read text like this.
Yes, it tends not to discolor things as much. but people really notice that they lose their quality of vision. So reading street signs, things like that, become very poor. But certainly reading text up close becomes a real issue too. And it is a cataract where the symptoms outweigh the presenting way it looks. Posterior subcortical cataracts can be quite difficult to locate. And so it's one of the forms of cataract that can go longer before it's diagnosed. So people can be quite impaired with it.
And they progress more rapidly.
They do, and they're the ones that are also associated with the steroids.
Ah, right.
So corticosteroid use is associated with the posterior subcortical cataract, so it can happen in younger people.
And preparing for this talk, I looked at the Cochrane site, and I learned that there is no evidence at all that vitamins will affect cataract progression. Yeah.
I mean, the big thing we talk about in terms of protection, decent sunglasses, because obviously the ultraviolet radiation can cause free radicals and you get an oxidative stress that way. So if you can have sunglasses, it may slow the rate. But when you compare that to if you've got a family history where you've got 9 times the risk in the first place, the sunglasses will probably only have a minor slowing effect.
But if you don't have a family history, well, it's worth having them.
It's worth having them, for other reasons,
Okay, so that brings us to the end of our talk. Thank you very much for listening, and bye.
See you.
See you.